So this is some orthopedics and rheumatology teaching. So we're going to cover most of the stuff on the core curriculum map, except these few things. We'll go over most of the stuff briefly because we don't have time to do everything in detail. So let's start with an SBA. I'll give you about 30 seconds to answer, and then if you could put your answer in the chat, or if you want to shout out, that'd be good. Any answers? No? Okay. So let's see what the answer was. So the answer was B. You need to. So this is a 69-year-old lady, came to A&E with a painful, swollen, tender erythematous calf. Recently to hospital for hip operation. Past medical history includes diabetes. So remember, the first thing is it's asking for initial management. So what would you do? You'd take a set of observations. So remember, when you're asked to give any sort of management, start with bedside, like labs and bloods, and then imaging and special tests. So in this instance, we're going to take some observations, and we also need to determine if she has a fever or she's systemically unwell, and then this will affect how we manage this patient. So just from this, it could be a couple of things. You should be thinking cellulitis, maybe DVT. At the minute, it's more likely to be a cellulitis because, but it's not always so obvious given her recent surgery. It could also be a DVT. So you should also investigate by doing a Wells score. Let's see. So cellulitis is an infection of the dermis and the subcutaneous tissue of the skin. We need to investigate by doing bloods, so FBC and CRP to look for any signs of infection. On the FBC, you'll be looking for white cells. And then in terms of your clinical examination, you're looking for erythema, edema, pain, sort of indistinct border that's not clearly defined. The limb may be warm, and you may also see bullae, which are like fluid-filled blisters around the area. In terms of what your risk factors for this would be, if they've had any previous episodes of cellulitis, if they've got any wounds or breaks in the skin, any ulcerations, also if they have athlete's foot, apparently that has it's associated with recurrent cellulitis. If they've got venous insufficiency or a past medical history of diabetes, that can also increase your chances of getting cellulitis. So how will we manage this? We need to give them antibiotics, and depending on the severity of the infection, this may be oral or IV. And generally, your first line is flucloxacillin. So I think that's one that I would remember. And if they're penicillin allergic, you tend to give clarithromycin or erythromycin. Yeah, also it's important to draw a line when you first see them to see where the border of the cellulitis is, and sort of safety net them to say that if it goes beyond this line or if it's getting worse, they need to be seen again. Also, in terms of your red flags and things you should be thinking about, so could it be a DVT? Because they can present very similarly, especially if it's not as obvious as in the picture we just seen. If it's just a red leg, it can look like a DVT. You need to safety net them, especially if you're in general practice, saying that, if it grows or gets any worse, they need to either come back or go to hospital. And then you also need to do sort of a review of them to make sure they're not septic. So take their observations, their vitals, and rule out sepsis. So second question. Any answers? Okay. So this one's actually quite hard, I think. By the way, these questions are written by MedSoc. So the answer is group A strep. So here what you're thinking is, has this turned into necrotizing fasciitis? So group A strep is the most common cause of necrotizing fasciitis overall, because it affects older people and younger people. And then, so it's a bacterial infection of the soft tissue and fascia. And there's 4 different subtypes, which are type 1 is polymicrobial, so that's aerobes and anaerobes. That tends to involve sort of Staph aureus and other multiple bacteria. Type 2 is your monomicrobial, which is usually your group A strep. And then type 3 is your gas gangrene caused by Clostridium perfringens. And then I think type 4 is like fungal and other marine organisms that are related, but that's not as important for us. And then in terms of your investigation, again, similar sort of thing. You're doing bloods, you'd take blood cultures, ABG, and with your clinical examination, with your early on, it's quite easy to confuse with cellulitis because it may just be erythematous, look similar to cellulitis, but then after a while it will develop quite quickly into swelling, a purple rash, there'll be blistering, and then you'll see usually the leg turning sort of black, and especially if they have gas gangrene, there may be crepitus. And then by sort of day 4 or 5, they'll become seriously unwell and have become septic, basically. And it's the similar sort of risk factors for cellulitis. Particularly important to consider if someone's also just had surgery, if the wound's infected. And then in terms of your management, you're going to give IV antibiotics. You need to escalate this as soon as possible. They could require ITU admission, and generally the treatment is surgical debridement. So serious condition.
Amit.
Mm-hmm. Sorry,
someone's asked, what's the difference between gas gangrene and necrotizing fasciitis?
So gas gangrene is a type of necrotizing fasciitis, I believe. So like I said, there's 4 types caused by different bacteria or fungi. So gas gangrene is caused by Clostridium perfringens, but it would present in the same sort of way, except I know gas gangrene's a lot more aggressive than the other ones, so that would require sort of immediate escalation for surgical debridement. And I think I'm not too sure, but they have different causes as well, and they're more common in different subgroups. So I would just go and look that up. Okay, next question. Any guesses? No, okay. So the correct answer is C. We need to send her for an ankle X-ray. So this woman has gone over her ankle during a netball match. Her ankle was swollen and tender over the outer ankle, and she is able to weight bear. So your thought should be you're worried about a sprain or a fracture. So you need to remember your Ottawa ankle rules. And in this instance, she has tenderness over the outer ankle, so that's bony tenderness over the lateral malleolar zone, so that qualifies for sending her for an X-ray. So with ankle injuries, a sprain is a tear in the ligaments that support the ankle, and this may be complete or partial. And the most frequent ligamental injury in the ankle is the anterior talofibular ligament, so that's on the outer ankle, due to the mechanism seen above. So they basically just roll outwards on their ankle. And 15% of these ankle sprains are associated with a fracture, so that's why it's important they get an X-ray. And then your Ottawa ankle rules are basically three things. So if they have inability to weight bear for 4 steps, tenderness over the lateral malleolus, that's sort of the bony bit that sticks out of the ankle, and then tenderness over the medial malleolus. So if they have any one of them things, that qualifies sending them for X-ray. And these apply up to 1 week after the injury occurred. So even if they come in a couple of days after they've done their ankle in, you still apply these. And
Got
you
a
don't need to
raised
know.
hand. I mean, just say.
Hmm?
Not sure someone's. Oh,
Thank
it's not
you.
raised anymore.
Could I ask a quick question? Or
Yeah, of course.
about this Ottawa ankle, I was told that it was like it requires 2 conditions, so it has to be that they have pain in the malleolar zone, and they need to be either unable to weight bear or elicit tenderness. Is it just that it's one of the 3 instead of 2 of the 3? I was told it the other way, but they might have told me wrong, just checking.
I think these slides may also be wrong, but that's a possibility. I believe, I think it's only one of them, but I would also double check. These slides could be wrong.
Sure, thanks for telling me anyway.
Sorry, I couldn't answer that better.
It is only one.
Yeah.
Okay, thank you.
Yeah.
Next question. You all want to take a guess in the chat? No? Okay. So the answer is reduced internal rotation. So this lady is coming to the GP complaining of pain in her hip for the past 4 months. She's got no other medical history and she's still able to get around. So I think key things to point out in the STEM is that it's been happening for 4 months. So this isn't something acute. Also her age, she's 76-year-old. So in this instance, you'd be thinking, is it possibly osteoarthritis, which in this case it is, and reduced internal rotation is one of the first sort of issues that you get with osteoarthritis of the hip, because the disease is still probably relatively mild, and then as it progresses, you'll get limited abduction and rotation of the hip, and then you'll get issues with flexion, extension, and adduction, and then sort of pain over the greater trochanter. Oops. Yeah, I think that's all there is about hip fractures, really. You do also get an antalgic gait, but that develops much later into the disease, so you wouldn't be there after 4 months. And then the positive Thomas test is used to test for sort of fixed flexion deformities in the leg. So that's not really relevant here. Go to the next question. Related. So this is a lady the same lady, she's tripped on the curb whilst out shopping and her leg is now externally rotated and shortened. And then this is what you see on the pelvic x-ray. I won't get any of you to present this x-ray, but do practice presenting your ortho x-rays. And so in this instance, the answer is arthroplasty. So you can see here where the fracture is. So this is a intracapsular fracture. So your management options would either be arthroplasty or hemiarthroplasty or a cannulated screw. In this instance, you wouldn't use a dynamic hip screw. And then given usually it's the age and the mobility, the baseline mobility of the patient. So this patient's mobile, able to get around, doesn't have any other comorbidities. So you'd opt for an arthroplasty. Okay, we're going back to hip osteoarthritis. So risk factors for hip osteoarthritis are age, obesity, vitamin D deficiencies, any trauma to the hip, if they do any particular high impact sports, also if they've got any like anatomical variants or any congenital conditions that can cause early osteoarthritis of the hip. And the symptoms tend to be pain around the groin area, which improve with rest. It's usually worse at the end of the day after they've been walking about, and they can get this stiffness and crepitus of their hips. And then, like I mentioned before, the first symptom that they usually notice is loss of internal rotation. And then they can develop this antalgic gait, which is basically just an abnormal gait caused by the pain. They develop a different way of walking. And then they get the reduced flexion and fixed flexion deformities, which can then cause a Trendelenburg gait. If you're not sure what this looks like, I'd suggest like looking at a video of it. It's basically when your hip drops to one side as you walk. And then the management can be challenging because it depends on the severity of the condition. So usually we advise lifestyle measures, so weight loss and exercise, and then pain management, so paracetamol, and then remember to work your way up the pain ladder, NSAIDs, and we could refer them to physio. But then if none of this works, or if it becomes too severe, they become immobile, they can't really get around, then we would consider surgery. And then remember your X-ray findings for osteoarthritis. So loss, which is loss of joint spaces, osteophytes, subchondral sclerosis, and subchondral cysts. This is something they like to ask questions about in OSCEs and AKT. So I'd remember those X-ray findings. And then back to hip fractures. This is another thing that you should just know off the top of your head because it's something they like to examine quite a lot. So it can be broken down into basically 3 types of fractures. So you've got firstly either intracapsular or extracapsular. If you see this diagram down here, the colored one, intracapsular is the blue bit, and then extracapsular is the orange and pink bit. And then the orange bit is trochanteric, so in between the greater trochanter and lesser trochanter, and then anything sort of below that is subtrochanteric towards the femur. And then with your intracapsular fractures, they need urgent review and management because there's a high risk of avascular necrosis of the femoral head because of the blood supply and the vessels that run around there, especially if it's a displaced fracture. So you need to also know your Garden classification to work out what your management would be. And if you break it down into, like I've highlighted the colors here for complete displacement, whether it's complete or incomplete, and the level of displacement, if you break it down like that, it's quite easy to remember. So type 1 is incomplete, undisplaced. Type 2 is complete, undisplaced. Type 3 is complete, partially displaced. And then you have type 4, which is complete and completely displaced. And then with your management, I find it's quite useful to know what the actual management looks like on an X-ray, because then you can sort of visualize how you would manage it, knowing where the break is. So if we start with our intracapsular fractures, if it's undisplaced fracture, so the bone's still there, there's just a break in there, you can use cannulated screws, which look like this. Oh, sorry, I'll change the slide. There you go. You can use cannulated screws, which just go through and hold it in place. Or then if it's a displaced fracture, again, depending on the patient's baseline mobility, if they are able to, they're active, they're able to get around before, you generally go for a full arthroplasty compared to a hemiarthroplasty, just because it's a bigger operation and it requires a patient to move and actually use their hip afterwards. So if the patient's bedbound, there's no point giving them a full, completely new hip because they won't use it and it'll become stiff. And then, yeah, if they're immobile, you go for a hemiarthroplasty, which is just one side of the hip is replaced. So just where the femoral head is, that's replaced, not the actual capsule of the hip. But also, if it's displaced and they're young, you can go for cannulated screws, but I think that's not as common. And then if you go for the extracapsular fractures, with your intertrochanteric fractures, you want a dynamic hip screw, because how that works is it's able to move around between the femoral head and the femoral shaft. So it gives it a bit of flexibility because it's in that bit in between. And then your subtrochanteric, which is towards your femoral shaft at the bottom, if you just stick a nail in there, so an intramedullary nail, that will hold it in place. Okay, next question. Any guesses? So this is a 53-year-old woman. She is coming to GP. She's got pain in the small joints of her hands. She's describing this swelling that's worse in the morning and gets better throughout the day. It initially started on one joint. Now it's on 4 joints of her hand. Symptoms have been getting worse over the past 6 months. She would have liked to come in earlier, but she couldn't find the time. So this question is actually quite hard. And the answer is refer to rheumatology within 3 days. So if you're thinking rheumatoid, you should be thinking rheumatoid arthritis because firstly, it starts in the small joints. It's swelling that's worse in the morning, gets better in the day compared to osteoarthritis, which is the opposite. It's better in the morning, gets worse with use throughout the day. And then the criteria for referral to management of rheumatoid arthritis is that if there is, you refer urgently within 3 days of presentation. You don't delay for blood tests for measuring anti-CCP or rheumatoid factor if they have small joint involvement of the hands or feet, more than one joint is affected, or if there's been a delay of 3 months or longer between the onset of symptoms from the person seeking medical advice. And then you would also offer them NSAID in the interim until they're seen by rheumatology, just to help with their symptoms. And then next question. So this patient's is another patient, 25-year-old, been referred to the rheumatology clinic. She experiences these sudden recurring episodes of joint pain and swelling. They vary in length, and after each episode, her joints feel fine as if nothing ever happened. So the answer to this is hydroxychloroquine. So this is palindromic rheumatoid arthritis, which is where you get these episodes of like the symptoms of rheumatoid arthritis, where you get the joint swellings, the joint pain, but then the symptoms resolve and you're absolutely fine, but then they come on and off. And then the nice recommended treatment for this is, first-line treatment for this is hydroxychloroquine. And I think that's just something, a fact to remember. So a bit about rheumatoid arthritis. This is an acronym on these slides, but I don't think it's particularly useful. I think the typical features just to remember are if they've got swollen, painful joints in their hands and feet that gradually get worse. So it starts in the hands and feet, and then it spreads to their larger joints. And then they have stiffness in the morning. This is usually lasting more than about 30 minutes. So that's morning stiffness. And then they also tend to get swellings of the joints. And if you squeeze their metacarpal and metatarsal joints, they'll get discomfort. So this is a positive squeeze test. And then it's also important to be able to differentiate these with osteoarthritis. So in osteoarthritis, you'll get more pain as the day goes on. And that will generally start in sort of the larger joints, so your knees, your wrists, and then go down to your fingers and toes. And then with rheumatoid arthritis, there's a lot of extra articular features. So if we go through these, you can get an increased risk of cardiovascular disease. You can get hematological symptoms, so anemia of chronic disease. And I think an important one to remember is the stuff that can happen with your eyes. So you get really dry eyes, you can get scleritis, you can get episcleritis. You can also get these rheumatoid nodules, which are typically on your elbows and fingers, and they're like firm, painless lumps under your skin. And then mononeuritis multiplex. And then one specific to rheumatoid arthritis is Felty syndrome. So that's the triad of splenomegaly, rheumatoid arthritis, and neutropenia. That's something that can come up in sort of AKT. And then you get thorax symptoms. So it's cause of pulmonary fibrosis, and then specifically Kaplan pneumoconiosis, Kaplan syndrome. So that's when pulmonary nodules in the patients with rheumatoid arthritis that have been exposed to coal, silica, and asbestos dust. You can also get osteoporosis and then other inflammatory conditions like vasculitis and amyloidosis. And then in a patient with suspected rheumatoid arthritis, we would, from primary care, you'd refer to secondary care, so refer to a rheumatologist, and then in the interim, you can give them NSAIDs for short-term relief. In terms of investigations, they're likely to do blood, so they'd measure their rheumatoid factor, anti-CCP, which is more specific, and then they'd also take x-rays of the hands and feet. And then the reason that quick referral is important is because early treatment equals improved outcome. And the faster we start treating them, the faster we can put their disease into remission, which is sort of the goal of treatment. And we monitor the treatment using their CRP and their DAS28 score, which is a scoring system that uses the number of tender joints they have, swollen joints. They have to get their ESR measured, and then the patient's asked to, like, for global health rating. I'm not sure if any of you have seen it done in clinic or not. And then the disease is in remission when their score is less than 2.6, and it's classed as high activity when it's greater than 5.1. But I don't get too caught up in the numbers, because I don't think that's that important for you to know. And in terms of the treatment, you'd start them on, firstly you start them on one DMARD, usually methotrexate. And then whilst you're starting them on this DMARD, you may give them a course of bridging prednisolone. And then if this doesn't sort of help their symptoms and bring down their DAS score, you would give them 2 DMARDs. And then again, if this doesn't bring down their DAS score, you'd try some biologics. So you'd start with TNF inhibitors, so entanercept, infliximab, or adalimumab. And then the last line is rituximab. And then if they have, if they're in remission and then they get any flares of the arthritis, the general treatment is prednisolone and an NSAID for a short period. Okay, next question. So this is 47-year-old male presents to a GP with right shoulder pain. It's been going on for 4 months, difficulty dressing, no recent trauma. He was a semi-professional tennis player and he couldn't raise his arm. So what you'd like to do is refer urgently to secondary care. Sorry. So you'd be thinking, has he had a tendon rupture or what's he done to his shoulder? So in this instance, it could be an acute rotator cuff tear on a background of tendonitis. This can occur without any sort of trauma with it. And then since he's a tennis player, there's a suggestion of repetitive stress of the shoulder and arm use. And then the NICE guidelines for urgent referral, if there's a possible acute tendon rupture, is sudden inability to abduct, so raise their arm, or pain, weakness alongside trauma. So he's had a sudden inability to raise his arm, so that would warrant for urgent referral. And the tear in the rotator cuff is most commonly the supraspinatus, and this is usually either partial or complete. And then when he's referred, they'd investigate this using shoulder ultrasound. And then the management's usually conservative, so it's physio, analgesia, a topical NSAID. And then if this doesn't work, then they'd consider surgical repair. Question. So the answer to this is C, cervical myelopathy. I think this was a bit of a tough question. Sorry, let's just go back. So yeah, it's cervical myelopathy. Let's go through the options and say why it's not the other one. So cervical osteoarthritis, I think that would be unlikely to cause these sort of symptoms. It would present more with just sort of neck pain. You wouldn't really get all your sort of weakness and loss of sensation or anything like that. And then cervical radiculopathy, which is pinched nerve, and the nerve's pinched as it leaves the spinal cord. This would cause pain in the neck, the shoulder, the arm, and sensory symptoms are more common than motor symptoms, and possibly he wouldn't be hyperreflexic. So the right answer is C, cervical myelopathy, because I think in the stem, the hyperreflexia gives it away because it's causing a upper motor neuron lesion, and it's more likely to cause sort of pain, loss of motor function, sensory numbness, and loss of autonomic function. And then specifically for cervical myelopathy, you can use Hoffman's sign, which is where you like gently flick one of the fingers on the patient's hand, and then if you see the other fingers on the same hand twitching, that's a positive sign. So degenerative cervical spinal disease. So cervical spondylosis is basically just arthritis of the spine, and it's quite a common disease. You get pain in the neck, and it's also quite common to get referred headaches. And complications of this include radiculopathy and myelopathy. And then risk factors for degenerative spinal disease are generally age, family history of it, if you've had any trauma, any previous surgery, or if you've had like a whiplash injury, so if you've been in a car crash, maybe. The symptoms, you're commonly asymptomatic, but then you can develop like arthritic symptoms, so neck pain, reduced range of movement, and then you get various neurosymptoms with if it's developed to myelopathy or radiculopathy, so motor and sensory symptoms. And then, like I mentioned, you can use Hoffman's sign specifically for myelopathy. And then to investigate, you would send them for a cervical MRI. And then the treatment options would be, if it's just general axial neck pain, conservative, so physio, NSAIDs, maybe some muscle relaxants. If they've got radiculopathy, that's NSAIDs, and then you can also consider neuropathic agents and medications like amitriptyline. You can send them to physio, and then depending on the severity of it, possibly surgery, but this has to be going on for quite a while despite conservative measures. And then if it's a myelopathy, surgical decompression is the sort of only treatment that would work for them. One more question. So this is a 83-year-old that's presented to A&E after a fall onto outstretched hand injury. And then on examination, her upper arm is painful, swollen, with a globally reduced range of movement. So out of these, the correct answer is C. So you need to check the sensation over the lateral shoulder. So from the stem, it sounds like he could possibly have an injury to the proximal humerus. Oh, sorry, 1 second. Oh, there we go. Yeah, so you need to check the sensation over the lateral shoulder because there could be injury to the axillary nerve area, which is also called the regimental badge. And then proximal humeral fractures are also common in elderly people who have osteoporosis and fall in this sort of way with their hand out in front of them. And then in terms of the management for this, it would generally be a sling to stop them moving their arm about. And if it's complex or like as bad as it is in this picture, complete, then you would consider surgery, or they'd need surgery. And then risk factors for this is generally osteoporosis, diabetes, and being female for some reason. And then this is just an outline of the upper limb fractures. We're not going to go through them in detail, but I think it's worth, so these are the ones that you should learn: the clavicular fractures, humeral fractures, radial ulnar, so nightstick, Monteggia, Galeazzi, and then for your wrist fractures, you need Colles, Smiths, and scaphoid. And then it's also worth remembering the different nerves in the hand and then what different injuries can cause what symptoms and presentations. And then this is just like a graphic at the bottom that I like to use to remember the difference between Monteggia and Galeazzi. Yeah, and this is a feedback form, if you guys would like to fill it out.
Is this the same feedback form that's shown each time?
Yeah, maybe we can just do it at the end.
Should we just do it at the end then?
Yeah.
Okay, thanks. Right, I'm going to go through the next lot of questions. So this is the next one. Feel free, if anyone's feeling brave, to suggest an answer in the chat or just unmute yourself. So Gemma's a 67-year-old woman who complains of disturbed sleep due to a deep pain around her right groin. Pain started 2 months ago and has slowly got worse. And it's worse on the days where she collects her grandchildren from school. She's tried paracetamol, which has helped. So can we have the answer, please? So it's the first one. The stem is sort of leading you towards osteoarthritis, which has already been covered in quite a lot of detail, so we won't spend too long on it. I think this is quite a hard question. Can we move on to the next slide, please? Because I think if you're suspecting osteoarthritis, you're very unlikely to actually investigate it with synovial fluid analysis. But maybe it's worth just being aware of like the buzzwords, like the coffin shape for SBAs like this. But I think in real life, you're not going to do synovial fluid analysis. I think the important ones you guys need to know for the exams are the gout and the pseudo-gout. So I put pictures up of the needle shapes and the rhomboid crystals. Just remembering that the gout crystals are negatively bifringent and pseudo-gout positively bifringent. And then there's a few others, but osteoarthritis has these coffin lid shapes with no bifringence, rheumatoid, so again, rhomboid shaped, but negatively bifringent. Okay, can we move on? So she has confirmed osteoarthritis. What's the single best description of the appearance of the X-ray? We've already had this explained, so it should be pretty straightforward. Okay, should we move on? I think we should all know that one, which is number 3, so the LOSS acronym. And the next slide, please. So this is just demonstrating, I think, quite nicely all the signs. I think the loss of joint space is quite self-explanatory. Osteophytes are just these sort of abnormal bone deposits or like spurs that are around the joint space. Subchondral cysts, they're like pockets of liquid under where the hyaline cartilage used to be. So they're like these areas of low density in the bone. Subarticular sclerosis is thickening of the bone where meets bone, so it just goes a little bit more high density in the edges there. So those are just in case they give you an X-ray and ask you to say the diagnosis. That's what you're looking for. Okay, next one, please. So this is her drug history. She's taking bisoprolol, amlodipine, aspirin, atorvastatin, paracetamol. So what's the next best step in treatment for her? Okay, should we have the answer? So the next best thing to do is to add codeine. I think this is also quite a hard question, so let's just go through it. Glucosamine, that's something that naturally occurs in cartilage, and there's quite mixed evidence showing that it actually has any benefit in osteoarthritis. So because of that, NICE do not currently recommend it, but patients can buy it over the counter if they wish to do so. So 3 is not right because topical NSAIDs are only licensed for hand or knee osteoarthritis. And then number 4, this is, I think, the one you should have been like torn between. The reason it's not correct is because you can't prescribe, or you should try to avoid prescribing NSAIDs if someone's already taking aspirin. The reason being, we can assume from her drug history she's probably had some sort of cardiac event, and the aspirin is prophylactic and working as an antiplatelet. And so if you prescribe NSAIDs as well, it can interfere with this beneficial effect of aspirin and also increases the risk of stomach ulceration, etc. Number 5, we don't use these for osteoarthritis. We do use intra-articular steroid injections to give short-term relief in severe cases, but there's a limit to how many times a patient can have these steroid injections. It's mostly used to like cover for important life events. So that the best one would be to add codeine. Okay, should we move on? So a 34-year-old Afro-Caribbean female presents to the GP with fatigue. She complains of a fever, joint pains, and the GP notices this rash. Given the most likely diagnosis, what is the most sensitive test to identify this condition? Okay, should we have the answer? So it's D, anti-nuclear antibodies. So the stem is describing SLE, and this is quite a classic presentation of lupus described here. And the picture is of the malar rash. So it's important you read the question carefully here because it's asking for the most sensitive test, which would be anti-nuclear antibodies. So essentially, if the patient is negative for ANA, it's very unlikely for them to have lupus. So it's a good rule-out test. If it were asking for the most specific, it would be between anti-double-stranded DNA and anti-Smith. So these are the most specific tests for lupus. So if they're positive, then it's very likely that the patient has lupus. So it's like a rule-in test. Make sure you understand well the difference between sensitivity and specificity for the exams because it comes up a lot. Okay, next one. So the same female presents to A&E with a fever, fatigue, and chest discomfort. On examination, you notice a pansystolic murmur loudest over the 5th intercostal space mid-clavicular line. Her ECG is shown on the next slide. So if we just see the ECG, I'll have to flick between, give you a minute to have a look at that. Okay. So given the complication that's developed, how should you manage her? So yeah, the answer is C, echo cultures and steroids. I think this is a really hard question. So she's likely to develop what's called Liebman-Sachs endocarditis. Essentially, this is a non-bacterial thrombotic endocarditis. So you get these like sterile vegetations on the heart valves. It's associated with malignancy, antiphospholipid disease, and SLE. So the echo is to diagnose it. Cultures to rule out infective endocarditis, which would be your main differential, and steroids to treat the underlying cause, which is the lupus in this case. The more common cardiac condition associated with SLE is pericarditis, but the ECG was actually just sinus tachycardia. So you would have seen the saddle-shaped ST elevation if it was pericarditis. But yeah, quite a tough question. Liebman-Sachs is quite niche, but now you know. Okay, next one. So this is just going through some of the main autoantibodies. So the anti-nuclear antibodies, which you mainly see in connective tissue disease. So we've gone over the SLE antibodies. You're definitely worth learning most of this table for the exams. The only one we haven't mentioned yet is antihistone, which is specific for drug-induced lupus. So they'll be positive for anti-nuclear antibodies, but not anti-double-stranded DNA or anti-Smith, but they will be positive for antihistone. So systemic sclerosis, we have the anti-SCL70, which is for diffuse scleroderma, and anti-centromere, which is for limited cutaneous systemic sclerosis. Then the Sjögren is anti-Ro and anti-LAR, rheumatoid factor, polymyositis and dermatomyositis, anti-Jo is the main one to know. Okay, and the next one. This is just some of the anchor autoantibodies, which you mainly see in vasculitis. So C anchor, which you see in granulomatosis with polyangiitis, and P anchor, which you see in eosinophilic granulomatosis with polyangiitis or Churg-Strauss, and microscopic polyangiitis. The atypical P anchor I wouldn't worry too much about. Yeah, next one. So a bit about lupus. It's a multi-system autoimmune disease, more common in women. Some of the risk factors are listed there. The symptoms are very, very variable because it's this multi-system disease. Everyone will present differently, basically. But the question we had earlier is quite a good. It'll be quite obvious in exams because it is such a variable presentation. So it'll be this fatigue, this classic malar rash, which is photosensitive, fever, myalgia, and arthritis. We've gone through the investigations you would do. Also worth mentioning that they'll have low complement as well. And the treatment is hydroxychloroquine. I think vision is just highlighted here because it's important to know that if you're on long-term hydroxychloroquine, the main side effect is retinopathy. And we use steroids to manage acute flares, which is why that was the treatment for the Liebman-Sachs. And conservative management can mention some protection. So some of the emergencies to be aware of, we've covered the endocarditis and also lupus nephritis. So all lupus patients will have quite frequent dipsticks to assess for proteinuria because this presents as nephrotic syndrome. And if you have a lupus patient with proteinuria, you're probably going to want to admit them and give high-dose steroids. The other one is cerebral lupus. That, again, is very non-specific symptoms. It can be seizures, psychosis, headaches. And again, you'll want to admit and give high-dose steroids. And we've mentioned drug-induced lupus and the antihistone antibody. Worth knowing the medications that can trigger it. The main ones I've put bold is just the hydralazine and the procainamide, but it's mostly the sulfur drugs to be aware of. Okay, next one. So 56-year-old female presents to the GP complaining of a rash on her upper back and arms. She has been fatigued over the past few months and had difficulty walking up the stairs. She's lost some weight recently and had a PR bleed. Given the most likely diagnosis, what should you arrange? Okay. So the answer is 2-week wait referral. So if we just move on to the next one. This is dermatomyositis, and importantly, well, probably the most important thing to know about it is that it's a paraneoplastic syndrome, mostly associated with like visceral cancers, so gastric, colorectal, genitourinary, and lung cancers. The photo in the stem was of this like shawl sign, and the other ones on this slide here, we've got the Gottron papules and the heliotrope rash. So if the patient had similar symptoms but none of these skin manifestations, then the diagnosis would be polymyositis, but because they have the skin, it's dermatomyositis. So yeah, the main thing to be aware of is that you need to investigate for a underlying cancer. The symptoms, there's difficulty, it was proximal muscle weakness. So in the stem, she was finding it hard to climb stairs. I've gone over the skin signs. Other investigations to do would be EMG, and you'd have raised creatinine kinase and inflammatory markers. And the main autoantibody you'd want to do in this case would be anti-Jo. This is just to show the difference between the two. Not sure if that's very useful. Yeah. So a 34-year-old woman comes to the GP complaining of back pain in her back, legs and arms. She also complains of significant fatigue. On examination, you see she uses a walking stick, but her gait is normal. There are several tender points across her back. Which of these is not a risk factor for the above condition?
So, can I ask a quick question about the last slide? Sorry.
Sure. Yeah.
Amit said it was more likely diabetes mellitus, but how does that relate to How does that relate to dermatomyositis?
Sorry, can we go back to the... Which slide are we talking about? This one?
Just the one before that. Yeah, this one here, where it says more likely DM. Are you saying that that combination of antibodies suggests it's DM instead, or? Oh, I see. Sorry, it's dermatomyositis. Sorry,
I think it's just I didn't make these slides, so the abbreviations are a bit confusing. But is everything okay there?
Yeah, that's fine.
Yeah.
Thanks.
Okay, great. No worries. Okay, should we answer? So it's A, the STEM is leading you to assume this is fibromyalgia, and the only one of these listed that's not a risk factor is previous disc herniation, and there's no association found for there to be increased likelihood of having a herniated disc in people with fibromyalgia. So if we go to the answers. So this is just a chronic pain syndrome. You have this widespread body pain, which I think it's just essentially means it's like front, back, left, right, and the main thing that the clue will be in SBAs is that there's like tender points to palpation will normally mean that it's fibromyalgia. So often associated with fatigue and memory difficulties, sleep and mood difficulties. Some of the risk factors were listed in the question before, so the rheumatological conditions, being female. Investigations will be normal, and the treatment is patient education, physio, CBT, and medications to treat neuropathic pain, so amitriptyline, pregabalin, duloxetine. The reason being because it's chronic pain state with, they think it's to do with a CNS-driven like pain amplification type syndrome. So you can't use nociceptive medications like NSAIDs or paracetamol. In terms of pain relief, the only ones that are really going to work here are these neuropathic pain meds. Other associated conditions are IBS, tension-type headaches, chronic fatigue syndrome, and there's a couple others like TMJ disorder, but they're not very relevant. Okay.
Hi, sir. Can I just quickly ask? Is there any way we could get the slides for this?
What do we know, guys? Can they get the slides?
Because I have to go now, but this has been so useful, so I want the slides.
I
I
think
know
they
it's
may
being
be sent out
recorded.
after.
Yeah, I know it's being recorded, so I'm sure there's a way of.
Oh, perfect.
Yeah.
Thank you so much. Thank you.
No worries. You're welcome. So the next question. A 57-year-old male presents to the GP with a painful wrist. He states his wrist is periodically painful for 1 to 2 weeks and then settles. This pattern has gone on for a couple of years. His past medical history includes hypertension, type 2 diabetes, and he is obese. X-rays are arranged. So if we see the X-ray. And go back to the question. So what's the most likely diagnosis? And go back to the X-ray if you need to. Okay, should we have the answer? So this is gout. I think this is quite a straightforward question. It's got a lot of the risk factors. If we go to the next slide, we've got some of the X-ray findings. So the main ones, you see this like joint effusion, which I think is what this arrow is pointing at. The joint spaces are usually quite well preserved, but you get these characteristic erosions that are on the left of the screen. And if it's a chronic long-term condition, you get these like gouty tophi, which are these soft tissue swellings we can see on the right side. Okay, should we move on? So gout is a crystal arthropathy associated with having high levels of uric acid. So some of the risk factors are being older, male, certain medications, having a lot of red meat, alcohol, and conditions with a high cell turnover rate, like hematological malignancies, myeloproliferative disorders. So the signs, it's red hot, painful, swollen joint, and it's normally the first metatarsal phalangeal joint. When you have a patient presenting with a red hot joint, the first thing you need to exclude is septic arthritis. So it's important that investigating gout, you do joint fluid aspiration, and then we'd have it under polarized light microscopy, which we've already touched upon. So some of the drugs, I think you need to learn a couple of them associated with the risk of gout. There's a few like tacrolimus, aspirin, cyclosporin, and in terms of treating it, the acute attack we treat with NSAIDs and colchicine. And then after about 2 weeks after when the symptoms have resolved, you want to start them on a preventative treatment. So something that lowers the levels of uric acid. So that's allopurinol and febuxostat, second line. Important thing to remember is that you need to have colchicine cover when you start them on a uric acid lowering therapy. So about 6 months, I think you need of colchicine or NSAIDs while you're starting that. And some of the complications are listed there. So joint destruction, kidney stones, kidney disease. Okay. This table is just showing you some of the differences between gout and pseudo-gout, which we've already touched on. It's worth looking up what chondrocalcinosis looks like on an X-ray because that can come up in exams. It's the main thing that's going to lead you towards pseudo-gout. You get these like little white blobs in the cartilage. It's like calcification in the cartilage. And that's because of calcium pyrophosphate. This table, I'm not going to go through in too much detail. It's from Geeky Medics, so if you want to go and look at it. But it's just some of the main findings you'd get when you do synovial fluid analysis. Again, we've already touched on it, so yeah. Okay, next question. A 63-year-old female was recently diagnosed with breast cancer. She comes to the GP for a checkup as she's due to start adjuvant hormonal therapy. She has no other past medical history of note, and she's a smoker. So what's the most appropriate next step for the GP? Okay, sure. I think this is quite a hard question for fourth year. I think it's more of a fifth year question. They essentially want you to recognise that she's at risk of getting osteoporosis. So the adjuvant hormonal therapy they're referring to is likely an aromatase inhibitor. So that's letrozole or anastrozole normally. And the main side effect of those is that it can reduce bone mineral density. The other risk factor she's got here is being a smoker. So essentially they need you to do a DEXA scan to monitor her bone mineral density and decide if she will need bone protection moving forward. Next one. So we've already spoken about osteoporosis a bit, and there's another not particularly useful acronym inside here. Essentially, it's just thinning of the bones, and there are tons of risk factors. It's worth being aware of the main ones, and some of the drugs that can worsen bone density. So there's not really symptoms. The main symptoms you get is you're going to have fragility fractures. And investigating it, the important thing to do is to calculate the fracture risk and do a DEXA. The treatment is important to make sure patients are calcium and vitamin D replete, and then you're probably going to start them on a bisphosphonate. Other ones to be aware of are the denosumab, raloxifene, teriparatide. You should probably know a little bit about those specific treatments, but you need to know about bisphosphonates in a lot of detail because that's comes up in exams a lot. And it could even be an OSCE station where you're counselling a patient on starting a bisphosphonate. There's quite specific instructions to do with taking it. So next slide. This is just a bit more about DEXA scanning, and you need to make sure you know the difference between osteopenia and osteoporosis in terms of the T-score, which essentially is just comparing the bone density to that of a healthy young person and how many standard deviations away that patient is. So we assess fracture risk using the FACT score or Q fracture, I think it's the other one. If a woman is over 65 or a man is over 75 or younger, if they've had any of these risk factors. So like in the question just now, starting certain medications or being on long-term steroids. So yeah, I think that's everything about that. Last one from me. A 23-year-old male comes to the GP complaining of a painful swollen knee. He feels well otherwise and takes no medications, and you see this on examination. What would you be most likely to find in the history on further questioning? So the answer is B. Again, I think this is quite a fifth-year question. It's basically describing reactive arthritis. So that's the triad of can't see, can't pee, can't climb a tree. We've got the arthritis described and the conjunctivitis on the picture. So let's just go to the next one. So yeah, this new sexual partner essentially puts him at risk of having an STI, which is a common cause for reactive arthritis. It's normally a genitourinary or a GI infection. Risk factors being male, HLA-B27 positive, having chlamydia or gonorrhea or GI infection, so especially Shigella, Salmonella, and Yersinia. So you've mentioned the triad of conjunctivitis, urethritis, and arthritis. And there are other systemic symptoms as well. So you can have fever and enthesitis, which is when you have inflammation where tendons insert onto bone. You can also have dactylitis, which is like swelling of digits. The image there is of keratoderma blanoragicum. And you can also get succinate balanitis, which is like an eroded glands. So the arthritis is usually asymmetrical oligoarticular arthritis that affects the large joints of the lower limb, so the knee or the hip. It's also important to do a rheumatoid factor just to rule out some other types of arthritis. And in terms of testing for STI and the GI infection, those will normally be negative by the time the arthritis has actually started. So they're not that useful. In terms of treatment, it's NSAIDs and, if severe, steroids. Yeah. This is just summarizing some of the seronegative arthritis. So the other ones in that question, I don't know if it's worth going back, they were essentially, the other options were describing symptoms, sorry, back again. The other answers were describing symptoms of other seronegative arthritis. So the previous knee injury, well, not that one actually, but rash on the elbows, psoriatic arthritis, touching toes is angst-bond, IBD was getting at enteropathic arthritis. So yeah, if we go to the table, it's just summarize the main points about them. But yeah, if you want to screenshot that, then go ahead. I'm not going to go through it in detail. Yeah, thank you.
Yeah, so on to the last batch of questions. Well done for sticking through, and I'll try and keep it nice and short. So let's move on. I'll give you a second to read this one. Got to be carried away there. Yeah, I reckon go forwards. So what we have is Hussein, an active 78-year-old man, has lower back pain and comes to see you in A&E. He reports both of his legs have been progressively weaker over the past week, and he feels a tingling sensation down both of his legs, which is worse when he coughs. He's experienced urinary incontinence but hasn't passed stool in 4 days, and he's concerned because he's lost any sense of feeling in between his legs. Now, on reading this question first, I want to reassure you that UCL will be a bit more straightforward with what they're actually trying to say, because it took me a while to realise that they're actually trying to describe cauda equina here. You've got this progressive weakness, which is making you think that there's something perhaps growing, or like a liquid that's increasing in volume and filling a greater space, which is impinging on the spine. But the features of cauda equina tend to be a bit more specific. So you have this like perianal numbness, the saddle anesthesia, so they can't feel anything between their legs, causing them to have urinary incontinence because they don't know that they're actually wetting themselves. And the tingling sensation down both of the legs, I think they're trying to allude to the bilateral sciatica that you do get in cauda equina, but the patient wouldn't be complaining about tingling. They'd be saying, I'm trying to walk down the road, I'm getting these terrible crippling shooting pains down the back of my legs. I think it would be a little bit worse than just some tingling. But regardless, whether you're thinking this is kind of like a malignant spinal cord compression or cauda equina, the investigation you want to go for is a whole body spine MRI. So it doesn't really matter too much, but UCL will be more clear with what they're actually going for. So yeah, move on to the next slide. So yeah, this is kind of the top two differentials that we're worried about here. And I've talked about the symptoms of cauda equina. A little trick for remembering like the difference between upper motor neurons and lower motor neurons signs, because it took me a little while to learn them, was that upper motor neuron signs cause things to be heightened because it's raised, it's up. So you get an increase in your tone and an increase in your deep tendon reflexes. And when you do the Babinski sign, the toes go up. Whereas on the other hand, with your lower motor neuron signs, it causes things to be reduced. So your tone and again, the deep tendon reflexes and the toes will go down when you do a Babinski sign. And alongside those LMN signs, you have the 4 Fs, which are fasciculations. So like the muscles just almost cramping and twitching. The the flexor plantar reflex, which is the Babinski sign going down, and flaccid paralysis. Whereas in upper motor neuron lesions, you get the spastic paralysis, which is like the muscle so tense that it's causing shaking of the body, whereas flaccid is just like droopy. And then the last F is if you see facial or forehead paralysis, so facial like palsy, similar to Bell's palsy, you're thinking that there's something lower motor neuron going on there. Thank you. Next slide. Right. So here, Hassan, a 25-year-old junior doctor, has come to see you in the accident and emergency department due to a severe knee pain that started 15 minutes ago. He's been recently training for a marathon and post 10-kilometer run was box jumping. Sounds bizarre. On landing, he says he heard a loud crack and his knee is now very swollen. You bend his knee to 30 degrees, pull forward and notice that the tibia slides forward against the femur, and you perform an X-ray, which is negative. So the key things in this question is firstly the mechanism of injury. So he's jumped off a box and landed, and that's when he's heard the crack. And quite a useful thing to do when you're doing orthopedics questions is to imagine the mechanism of injury, because when you're jumping off the box, you're going to land, and that would cause the planted surface, the area below the knee, to lunge, and that would cause a rip of your ACL. So this is what this is going for, an ACL tear. And then the second thing is bending his knee to 30 degrees. They're relating to the Lockman's test there, which isn't actually first line. You tend to do like an anterior draw, so the leg would be at 90 degrees as opposed to being at 30, and you're pulling forwards and feeling that laxity of the area below the knee, showing that the ACL isn't quite doing its job. And yeah, regardless, for most of these ACL, PCL, MCL and LCL injuries, RICE and a bit of physio. And if that doesn't work, then you're going to need some form of surgery to correct that injury. Thank you. Okay, so Shelia, a 13-year-old girl, comes to see you at the GP surgery alone. She has pain. A 13-year-old coming to the GP alone. Sorry, she has pain around her knees, which she thinks is growing pain, but isn't quite sure. She's recently hit her growth spurt and is a very active runner and dancer, and she notices the pain is worse during her runs and dances, but she carries on as this is her passion. There's a painful lump just below the knee, which is worse on palpation. What is the single best action for the GP to take? Does anyone put anything in the chat? Probably not. Probably not. Okay, so what's important in this vignette? So they're thinking it's growing pains, and growing pains is a bit of a misnomer because growing pains are actually benign idiopathic nocturnal limb pains of childhood. And the thing with growing pains, the key for growing pains that you would see in a question is they're complaining of pains at night, but then they wake up the next day and they're feeling fine, and these pains aren't affected by physical activity. So you go on a run and you start feeling pain, it's probably not going to be growing pains. And lots of GPs do like to just shun people away with its growing pains and it'll all be okay. The next thing, the key is that there's a painful lump just below the knee, which is worse on palpation. This kind of opens your mind up to a couple of different differentials. It could be Osgood-Schlatter's disease, which is where the tibial tuberosity grows abnormally, and you can see it in some people, like I've got it in both knees, and you just get a bulge of that tibial tuberosity, which can be treated if it's causing severe pain, and they essentially cut open the front of the knee and shave that. Otherwise, it's just left, and you can again give lifestyle modification and NSAIDs. It could also be patellofemoral pain syndrome, which is worse with exercise. So I think that's what this is trying to point at. And if the stem of the question was to say that she's finding that after her runs, the pain is slowly improving. So each run she does, the pain is less and less and less. You're going more for a patellar tendonitis because the quad muscle is building to help almost stabilize that tendon, so she's not in as much pain. Yeah, next slide. Okay, so Roshan, a 16-year-old Asian boy, is seen at the oncology outpatient department following urgent referral from the GP. He initially presented with weight loss, knee pain, knee swelling, and multiple pathological knee fractures from the ages of 14 to 16. And he has a past medical history of retinoblastoma as a neonate, and the consultant decides to perform an immediate knee X-ray. What's the single best description of the most likely finding on an X-ray? Right. Yeah, so this one, like a lot of the other questions, is a bit unfair. And it's one of those annoying ones involving the differentiation of bone tumours. There are a couple of little tricks that you can read from the question to kind of decide whether this is one of the benign tumours or whether it's more malignant. The fact that there's weight loss present is making me think that the tumour is like metabolically hyperactive, so it's requiring more from the body and taking more from the body and causing weight loss as a result. And the fact that there's some knee swelling kind of implies that it's a faster like growing process. It's taking place quicker than something that would be considered benign, and you wouldn't tend to have as much knee swelling as a result of that. And then the last thing in the vignette is the past medical history of retinoblastoma, which, if you don't know, is the most common malignancy of the eye in children. And it presents with a loss of a red reflex. You shine the light in the eye and it's just gone. And in fact, the red reflex is replaced by a whitened pupil. If a question like this does come up, realistically, it's going to either be osteosarcoma or Ewing's, as these are the two most common types to be aware of, with osteosarcoma being slightly more common. And osteosarcoma has associations with retinoblastoma, history of radiotherapy, so they might have had one of the lymphomas or one of the leukemias as a child, and Paget's. So you'd see an isolated raised ALP. Yeah. Go to the next slide. Okay. So this is just quite a nasty slide. There's a lot going on here, but the key stuff that UCL like to test are these typical findings on imaging. So in osteosarcoma, you see this sunburst pattern. It's quite self-explanatory. It's just kind of like an eruption outside of the bone. And in Ewing's, you get this onion skin. So as it describes this layering around the bone, it can cause almost like a bulb around the bone of just multiple layers. And then Codman's triangle. You might not be able to see it very well on the bottom right picture, but essentially it's almost like a fraying of the bone. Like if you were to snap a piece of wood, some layers almost shard out, and that's what that Codman's triangle is. It's where it's splitting. It says here that osteosarcoma is more commonly in the knee and Ewing's is more commonly in the pelvis, but the thing to know about osteosarcoma is that it most commonly affects long bones that surround the knee as well as surrounding the shoulder. So if it's direct in the knee directly, I wouldn't really be thinking about osteosarcoma. I'd be thinking it needs to be more in the neck of the tibia or of the femur. And yeah, they've highlighted blue cells, but honestly, until I signed up for this tutorial, I hadn't actually heard of it, so don't worry too much about that. Thank you. Next slide. As before, if anyone wants any clarification or any questions, just let us know. So a 45-year-old woman comes to see you in A&E. She's in severe distress as she's experienced an injury during football training where a teammate two-footed her in the shin. She cannot bear weight on her left leg or move it, and all peripheral pulses are present. And there is pain despite regular morphine, and an X-ray shows no abnormality. However, the urine is noticed to be coloured red. What is the single best management step to take? So we're going to have to do an immediate fasciotomy. So if you see a vignette that says pulses are normal and there's pain out of keeping with a clinical examination, and that's what they're hinting to with the fact that the X-ray shows nothing, and was there anything else in there? Yeah, X-ray shows nothing, and it's also non-responsive to analgesia. You're thinking about compartment syndrome, and you diagnose compartment syndrome by taking intercompartmental pressures. You'll never see it on the wards, but it's just something to kind of learn. And the fact that the urine is noticed to be coloured red is pointing at myoglobinuria. So in compartment syndrome, as the name describes, the muscle is sat within a compartment surrounded by fascia. And if there's an injury to that muscle, it causes a local inflammation of the muscle itself. But if it's contained within a compartment, it can't expand as much as it kind of would like, because it has this fascial boundary. So it causes a severe pain. And if you give them some medication, while the vascular supply is there, as a result of this, the massive inflammation, the analgesia can't quite do its job. So in this case, you just have to take them into the theatre, make an incision and cut that fascia to let it breathe, per se, and give them some fluids to kind of flush out the kidneys, because rhabdomyolysis and myoglobinuria can lead to an AKI. So you just give them fluid support. Yeah, and I think is that on the next slide? Might not be. All right, there's the feedback form again. Okay, next slide. And again. Thank you. Okay, so hopefully you've had a second to read that and think about perhaps what they're pointing towards. So Janine is a 52-year-old known intravenous drug user, and she's come into A&E with a limp. She says her knees become swollen over the weekend and she struggles to walk on that side. You notice there is inflammation and tenderness around her knee, and pain is worse as she walks around A&E. What is the single best imaging investigation for Janine? So we're going to do an MRI. So this kind of vignette is making us think of, there's a couple of possibilities of what could be going on here, but it's asking for imaging. So when you see IVDU, you're kind of thinking about an infective process, be that sexually transmitted infections such as chlamydia or gonorrhea, or more specifically, things like salmonella. And if you see IVDU in the context of osteomyelitis, you're thinking that this is salmonella rather than, I think it's, what am I saying? Yeah, salmonella. We'll leave it at that. The knees become swollen over the weekend and she struggles to walk on that side, and you notice there is inflammation and tenderness. So again, it's kind of in keeping with an inflammatory process and perhaps potentially early stages of an infection. And you're going to want to have a look at that bone to see if you can see any signs of that infection. Local edema in the region of pain. If the question was to say, what is the most appropriate initial investigation, it wouldn't, I would argue that it wouldn't be an MRI, and it would in fact be like a joint aspirate, because there is still a possibility that this could be for like a septic arthritis, especially seeing as they've decided to choose the knee as the focal joint. Yeah. So next slide. Okay, before we start this one, so I think it's pointing at osteomyelitis, and there are two main types of osteomyelitis, which are your hematogenous types, so it passes via the blood, and non-hematogenous. So that's where you have the passage of bacteria from surrounding tissues, and the patients that are more susceptible to these sorts of infections are, your diabetic foot ulcers, your peripheral arterial disease associated infection patients, and to confirm a diagnosis, you take a bone biopsy and culture that biopsy to see what's come up. Fine. So now they've gone and they've asked a couple more questions, and they find that she hasn't actually injected drugs for the past 5 years, but has a diagnosis of sickle cell anemia. What is the single best treatment for her? Ciprofloxacin. So I got myself a little tripped up earlier on. It's not IVDU that's related to salmonella, it's actually sickle cell anemia. So if you see sickle cell anemia, that is when you're thinking salmonella. And that's why the treatment here is ciprofloxacin, because ciprofloxacin is what salmonella is sensitive to. If it wasn't sickle cell anemia, the more common types of bacteria that cause it are your staphs, like your Staph aureus. So the first line would be flu-clox, and then if that patient is pen allergic, which a lot of the questions tend to be, you're going for your clindamycin instead.
So basically, if a patient has sickle cell anemia, then it's most likely to be salmonella.
Honestly, if UCL says sickle cell anemia, it is salmonella, and if it's not, you can come find me somewhere in the hospital and give me a slap. It will be salmonella, I promise you that.
Okay.
They're very, they wouldn't take risks and try and throw you off. Yeah, salmonella. And I think IVDU, unless I'm mistaken, might be like strep pyogenes. Let me see. IVDU is, oh no, it's staph. Boring. Yeah, IVDU is staph. Okay, Staph aureus. Right. So
if they have IVDU, then it's more likely to be Staph A.
Yeah, and staph's the main cause anyway. Okay. So if you remember, yeah, staph's the main. Staph aureus is the main cause anyway.
Okay. Cheers.
Yeah, and I guess a decent way to remember that is like a lot of the skin stuff tends to be Staph aureus, like cellulitis, Staph aureus, and you're putting a needle through skin. So you can kind of think of it. It's a silly way of thinking about it, and it's got no science behind it, but I guess you could think about it like that. So a 12-year-old boy has come into A&E with an acutely swollen right knee, and he cannot bear weight on his right side and looks unwell. The child sits still and is reluctant to move, and an ultrasound of the joint shows increased fluid. What would not help you to determine the suspected diagnosis? So the answer is CRP. So a swollen red hot knee in exams is septic arthritis until proven otherwise, and you want to rule that out first because it can kill people. Yeah, so the ultrasound of the joint is showing that there's some increased fluid, and increased fluid kind of suggesting a exudative process. And as you may know, that like in your pleural effusions, exudative processes tend to be more infective, and CRP is just a very non-specific marker of an inflammatory process. So in criteria like the kosher criteria, which is on the next slide, it doesn't really have any bearing. Yeah, with regards to like ESR, I don't know if you guys know exactly what it is, but it's your erythrocyte sedimentation rate. So they take a sample of blood, and they essentially just see how quickly those red blood cells are sinking down in that sample. So if the ESR is raised, there's either something wrong with the red blood cells, like you can sometimes get it in sickle cell anemia because the blood cells are sickled, and essentially the mass of the red blood cells is reduced in comparison to the absolute gravity of the serum, so the red blood cells don't sink as quickly, so you get an increased ESR. Or in infective processes, the reason it's raised quite often is just because the serum is so saturated with other stuff. You know, you've got antitoxins floating around, more white blood cells and that's circulating around, so it's harder for the red blood cells to sink, so you get a raised ESR. It's an awkward one to remember, and this is only in kids. The kosher criteria is only in kids, so just bear that in mind. So it's more for 5th year. Final question, even though we jumped from 29 to 31. Which of the following is a classification system for open fractures? I hadn't actually heard of this until I looked at the slides, so I wouldn't say it's massively high yield, but it's one to just bear in mind. So you're thinking about your Gustillo-Anderson criteria. Go on to the next slide, and it kind of covers what it is. So yeah, gradings of 1, 2, 3A, 3B, 3C. You've got 1 centimetre and the wound is clean, 2 centimetres and the wound is clean, 2 centimetres or more and the wound is clean, or a segmental fracture / open fracture with extensive soft tissue injury. So a segmental fracture tends to be a fracture that I've frozen. We're good. A fracture where the bone is broken in 2 aspects. So kind of like a complete fracture that passes from one side to the other. You describe that as a segmental fracture because it's broken the bone into segments. And yeah, whether it's A, B, or C is just dependent on the quality of the soft tissue and kind of how much how high risk the injury is. But regardless, in the cases of open fractures, they require early debridement. So take away that dead, damaged tissue. Perhaps take a graft from somewhere. You might need to replace some of the vessels with like your long saphenous in your leg or so on, and irrigate it with saline because that is quite a toxic environment that can lead to sepsis or other forms of infection. And I think that is all. Yeah, there was a lot going on there, and thank you to the other 2 for doing their bit. Is there anything in particular people wanted to ask? It doesn't necessarily have to be about the slides. I'm happy to try and answer any extra questions if needs be. I reckon that's a solid no. So I'm going to let you guys enjoy what's left of the evening, which isn't very long. And yeah, good luck with everything.
Thanks so much.
No worries.